Hello, my name is Thomas Danne. I am happy to tell you something about how we plan to accelerate clinical adoption of new type 1 diabetes therapies. I'm the Chief Medical Officer of an organization called Breakthrough T1D, which is one of the, or actually the largest funding organization, NGO, for type 1 diabetes. I'm the Chief Medical Officer of this organization, and at the same time, I'm a professor of pediatrics at Nova Medical School in Lisbon. So, to move this on, those are the things that I want to tell you today. So, what are medical affairs? How do we have to think beyond insulin in type 1 diabetes? Why are we accelerating cell therapy for type 1 diabetes? What does that mean for the future care model of type 1 diabetes? And then finally, is there a role for once weekly insulin in type 1 diabetes? So, why do we need medical affairs? Well, you might have seen that Barbie has been very, very successful since it was just opened. And we have Barbie now available in the store. And the people with type 1 diabetes were extremely happy to see that, also with diabetes, you can be Barbie and you can do everything. And this little Barbie had a continuous glucose monitor, had an insulin pump, and it has a blue polka dot outfit, like the sign of the blue circle for diabetes, and a little purse where she can have all the essentials that are necessary for somebody with diabetes. But the good story here for Barbie is basically that, yeah, she has something where we don't really see that the same penetration has already happened in the type 1 diabetes population. This goes, of course, for low and middle income countries as well as for high income countries, like, for example, the United States. Just imagine that in 1999, CGM, continuous glucose monitoring, became available, but it was recommended in the standards of care of the American Diabetes Association only in 2011. Also, if we think that automated insulin delivery is available since 2017, the clinical adoption has been slow. Right now, the estimated numbers are something about 16 to 30% of the type 1 diabetes population in the US have such a device. And if we look for disease-modifying therapy, Tzield, teplizumab, the first drug that delays the insulin need in early detected type 1 diabetes, was approved by the Food and Drug Administration in 2022, but still only 400 to 600 individuals have been dosed. So the guidelines that Breakthrough T1D published in the September of 2025 was really needed to move this forward. So this is why our organization has now said, well, research is very, very important, but at the same time, we also need to work with forwarding the regulatory affairs, the health policy, and we also need to look into medical affairs to improve clinical adoption. And what is my job together with the team in medical affairs? Well, we have to think beyond insulin. And I always say, well, it's a similar situation that we had in dermatology or rheumatology. In rheumatology, we had painkillers. In dermatology, we had ointments on the skin. But now we understand that these are autoimmune diseases, and we need to address the underlying disease. And the same goes for type 1 diabetes. Type 1 diabetes is not a metabolic disease like type 2 diabetes. It's an autoimmune disease. And we have to look into how do we treat the underlying disease. And insulin is a little bit just like a painkiller in rheumatoid arthritis. And so we understand now that type 1 diabetes is really in different stages. It looks as if all of these stages are at the same timeline, but this is, of course, not the case. Stage 1 might be a very long period of time. Dysglycemia, stage 2 could be a very short period of time. And then stage 3, where there is still a little bit of beta cell function there, but there is a need of insulin. This will take some time before we have really stage 4, when there is no residual insulin anymore available. And we actually can then only treat with insulin or, and this will come in a minute, with cell therapy. So this model of the different stages really is guiding the therapy that is happening here. Now, what can we do against this autoimmune disease? And you see there is a lot of drugs which we are actually looking at different stages of this immune process. Only one of the treatments is FDA approved, teplizumab, an anti-CD3 antibody, but there are many more to come. And we can imagine that we really have to become immunologists as diabetes doctors, really to find the right combination. And I always use the example of oncology, because I believe that, we will have personalized medicine to keep as many beta cells alive as possible, as early as possible, as early as we identify diabetes in type 1 diabetes in people. Coming back to the technology, it is always also important to see, where we are and what this really means. For example, there were many starting ways for the automated insulin delivery. For example, first we just had the sensor and the pump separately. Then the sensor was able to stop the insulin when there was a threshold reached. And the next stop was that there was a predictive stop for hypoglycemia risk called predictive low glucose suspend. But really the big breakthrough was when we had the possibility to automatically change the insulin up and down, as with the new hybrid closed loop systems. And maybe even at some time we will reach the point where we have multi-hormone systems which don't even need a meal input into the system. So there will be many things coming, but right now the standard of care is an AID system which is modulating the insulin dose depending on the glucose up and down, and maybe even stop the insulin altogether in certain situations. So if we have this fantastic automated insulin delivery, why do we actually still look for cell therapies? Why do we need these cell therapies? Well, simply because the technology is not a cure. You can see here in this study that was published that severe hypoglycemia and impaired awareness of hypoglycemia still persist in people with type 1 diabetes, despite diabetes technology. And as much as we still have an infusion set failure in these things, DKA is also happening. And very often with all this technology, we have lots of skin issues. So there are many, many reasons why it is not ideal. And we believe there are still very big unmet needs for people with type 1 diabetes, although we have this very good diabetes technology. And it's important to put this out there to say, yes, technology is great, but there is still an urgent unmet need to make it better. And this is kind of the roadmap. You can see on on the top how this roadmap is going, that we, moved on from low glucose suspend to hybrid closed loop. Maybe sometime we will have a fully closed loop. Maybe sometime we will have a multi-hormone fully closed loop. On the other side, the cell therapy is also moving forward. We have now manufactured cells coming up, and there are already the first ideas. How can we be immunoprotective, or with gene editing that maybe even less immunosuppression is needed, or maybe no immunosuppression would be needed. So here you just see two papers that have just come out in recent weeks, which would show you, that we are really here in a very special situation, very close to new ways of treating type 1 diabetes. And take a look at these publications. And just to give you a glimpse, you can see here this with the manufactured islet cells called Cell from the Vertex. These people who have gotten these cells, in the very big majority, have no longer a need for exogenous insulin. They don't have the severe hypoglycemia anymore, and they have an A1C in the near normal range. So if this is going to happen, what does it mean for the care team, for diabetes of the future? Well, we really see that the complexity of type 1 diabetes treatment has really significantly changed over the last decade. And we see that, on the other hand, the new things are not used in the clinic as quickly as we were hoping for. We also see that, of course, we need clinical trials to really figure out what works really in the real world. And we need more volunteers that actually work in these trials to make this happen quicker, so that we have evidence. So in order to do all this, we really need much more education. And Breakthrough T1D is putting out lots of educational offerings. And please look in our website to find something that might fit your needs. Here is this website, and here you can actually look at the QR code, and please do so, because there are the resources for you up to date. So what are the ideas that we have? How can we actually look at the future of the next care model? Well, basically, you see that we have, on the one hand, the knowledge for autoimmune delivery. We have the need now to understand the immune therapy. Telehealth is necessary because we cannot have an expert in every rural center. I don't have to tell you that in India. Early detection is needed. Screening has to be put in place. And eventually, we also have to know everything about cell therapies coming up. So we really have to develop those expert centers and those experts that are working there, of all the different multidisciplinary healthcare professionals. And in order to develop this, we had made a meeting where we had 7 centers of multidisciplinary teams of actually working in such centers already, who are able to do the cell therapies, but maybe still need a little bit of information on the modern diabetes therapies. And you see lots of smiling faces, and it's really great. And we hope that we will have a template for how such centers work. And we have invited those centers globally, and hopefully we'll have a template for others to build on this. So, what are what is the roadmap for this center of reference? Well, on the one hand, we are looking, of course, at the at the way how the cell therapies are done. And you need not only an endocrinologist, but you, of course, need somebody with immunology knowledge. You need the psychologist, the transplant surgeon, the person who is managing the whole transplantation part. And of course, again, the telehealth, as I already mentioned before, is necessary on this. So finally, we now were very much in front and said, how's the future going to be? Um, is there also news about insulin? And I don't have to tell you what a big stigma diabetes has. And we discussed whether with this new um, once weekly insulin, it might be an offer to basically keep people who have difficulties in managing their daily type 1 diabetes, that have frequent DKA and have difficulties in achieving the even very modest goals, might be eligible for such a once weekly insulin, because it helps you with the storage of insulin. It reduces the need of education, and it might actually, yeah, also improve a little bit the issue of disease-associated stigma as a barrier to the the disease management. And this could be an intermediate period to actually treat with only long-acting insulin once weekly, basically to keep people alive. And if we look here, we already looked this under a more controlled issues. Yes, there is, of course, with such an insulin, a much big, or not much, but a significantly bigger risk of hypoglycemia. But if you kind of even think, well, maybe for such people to make it very, very simple, and where there's education not possible, maybe a once weekly insulin will be better than premixed insulins or unregular insulin taking, maybe even without mealtime insulin, just to reach a very modest control and avoid DKA. I think this has to be studied scientifically, whether this is a new strategy for some of the low and middle income countries. And I look forward to discussing this further with you. We wrote this paper here, reviewing all the possible insulin strategies, and proposing this as something that needs to be looked at scientifically. So we really would basically work on the experience that we have seen of initiatives like the once weekly tuberculosis chemotherapy, which was also very successful in addressing disparities and other global threats. And maybe this shows us that this could also be with the once weekly insulin an alternative. And I invite you to come up with good scientific ideas to study this. So you see, I think I hope I made an optimistic picture showing that the T1D research is actually really moving forward very, very quickly. If we see the last 25 years, where there were no beta cells that could produce insulins, we have now manufactured islet cells and diverse protection strategies ongoing. The immunological targets that were there have now been moved forward, that we have one FDA-approved therapy and many more disease-modifying therapies already in clinical testing. We are able to diagnose type 1 diabetes much earlier with the antibodies. And we also have not talked about this, but where there are other adjunctive therapies that we can think of to reduce the cardiorenal risk in studies. So thank you so much for your attention. Greetings from our medical affairs team. And please help us to make every day with type 1 diabetes better, as we all should not stop until the condition is a thing of the past. Greetings from Breakthrough T1D. Bye bye.